This review, published this June in Biological Psychiatry, titled Immunogenetic Variants in Major Mental and Neurodevelopmental Disorders, is part of a special issue on brain-immune communication, and it asks a deceptively simple question. Do the genes that run our immune system also shape who develops conditions like depression, schizophrenia, and autism? Here's the setup. Major mental disorders, bipolar disorder, recurrent depression, schizophrenia, autism, and ADHD are common, chronic, and remarkably heterogeneous. Two patients with the same diagnosis can look nothing alike and respond completely differently to treatment. For a long time, the brain was considered immune privileged, walled off from the immune system. We now know that's wrong, and critically, somewhere between 20 and 40% of patients across these disorders show chronic low-grade inflammation, elevated C-reactive protein above 3 milligrams per liter, and that inflammation tracks with treatment resistance and cognitive decline. So, the authors ask, is some of this written into the genome? The review organizes the evidence around the two arms of the immune system. The innate arm are fast general first responders, pattern recognition receptors, like the toll-like receptors, and the cytokines such as IL-1 beta and IL-6. And the adaptive arm, the specific learned response, dominated by the HLA genes on chromosome 6 that present antigens to T cells. The authors comb through candidate gene studies, genome-wide association studies, and rare structural variants for both. On the innate side, the signals are real but modest. Variants in toll-like receptors 2, 4, and 9 associate with schizophrenia and bipolar disorder. Cytokine genes, the interleukins, TNF, and CRP itself, turn up across depression, schizophrenia, autism, and ADHD. Two examples to make it concrete. The IL-1 beta variant RS16944 raises IL-1 beta levels and is linked to bipolar disorder and to more severe depression in people exposed to childhood adversity, a gene-by-environment effect. And an IL-6 variant, RS1800795, is tied to higher IL-6 and to depressive symptoms following stress. The honest caveat, the authors stress, many of these need replication, and Mendelian randomization points to IL-6 signaling as possibly causal for depression and schizophrenia, which is the part that matters for drug targets. But the strongest and most elegant signal is in the adaptive arm, the HLA region. This is the top genetic hit in schizophrenia and bipolar disorder, full stop. Here's the punchline of the whole paper. There's an ancestral haplotype called 8.1, a block of HLA genes, inherited together. Normally, 8.1 is pro-inflammatory, associated with autoimmune disease. But in schizophrenia and autism, it's actually protective. Why? Because the 8.1 haplotype is missing a copy of the C4a gene. C4a drives synaptic pruning during brain development. Too much pruning increases risk. Less C4a means less pruning and protection. Now, the same haplotype in bipolar disorder does the opposite. It's linked to rapid cycling and suicidal behavior through its pro-inflammatory side. So one block of immune genes pulls in opposite directions depending on the disorder and the developmental window. That, to me, is the most important idea in this review. Immunogenetics in psychiatry is not one-size-fits-all. So where does this leave us? The authors argue the field is finally mature enough for clinical translation, but with caveats. Effect sizes are small, directions of effect diverge between disorders, and gene-by-environment interactions are understudied. The opportunity is patient stratification, using immunogenetic profiles plus biomarkers to identify the inflamed subgroup of patients who might actually benefit from immune-targeted therapies. The precision psychiatry vision that needs multi-omics integration, functional validation, and deep phenotyping. My one critical reflection, this is a narrative review, so it's vulnerable to selection bias, and the protective versus risk story for 8.1 is compelling, but still mechanistic inference, not proof. To sum up, immune genes are genuinely woven into the genetic architecture of mental illness, across both innate and adaptive arms. The C4, A, and 8.1 haplotype story shows the same immune variant can protect or harm depending on context, and the real prize is stratifying patients to match them with immune-targeted treatments.